just a brief introduction about what I do. I'm an oral maxillofacial surgeon. I work in Sussex, but have consulting rooms in London. And some of you may be familiar with oral maxillofacial surgery, some may not. So two things really I wanted to achieve from today. One is to introduce the specialty, and for short, we'll call it OMFS because it's a bit of a mouthful, and that's not meant to be a bad joke. But we'll just call it OMFS throughout. Some people refer to it as just maxillofacial surgery. And I thought by talking through some of the medico-legal pitfalls that I encounter in my day-to-day practice and my medico-legal practice, I hopefully allow you to develop a checklist to help you screen claims, especially if it's something they haven't dealt with before. So essentially, you can develop a schema by discerning what is viable and what's not in a claim. So what does the specialty cover? So essentially on the non-surgical side, we do have a non-surgical side, which essentially looks at the lining of the mouth, things like oral ulcers, infections, but the spectrum is very diverse, and that's because the origins of the specialty. So most people who are consultants or oral maxillofacial surgery or registrars are duly qualified in dentistry and medicine, and then we undergo surgical training, and hence historically the specialty arose from something called oral surgery, which involves surgery in the mouth. So as part of our practice, we cover surgery on impacted teeth, cysts and tumors of the jaws. We deal with dental implants, items such as facial pain, jaw joint symptoms, facial trauma, whether that's due to assault or road traffic collisions, diseases of the salivary glands in the face, diseases with aesthetics and facial disproportion, head and neck cancers, and there's a very few of us that deal with pediatric, and these tend to be things like cleft palate, developmental conditions of the face, which can be independent or part of other syndromes. But I'm going to go through each one, and I promise I'll try and keep it as lively and not boring as possible. But it is an interesting and diverse specialty, as you can see. So just to put things into context, this is data from NHS Resolution, and over a 10-year period, there was over 1,000 claims against oral maxillofacial surgery. The next set of data, as you can see, this is from 2009, 2010 to 2020. So the next set of data isn't out yet from the UK. If anyone is interested, I've got some global data that I can share with you. Obviously, it varies, when you look at places like the US or other countries that have a no-fault compensation scheme, unlike our scheme in the UK. So there's been a steady increase in the number of claims. I bet you're not surprised about that. Almost 600 claims were closed or settled, and as you can see, the majority were closed or settled with 281 with no damages paid, but when they do pay damages, they tend to be quite significant, with a total cost of over 32 million. And here is below you can see the breakdown in terms of the sums involved in damages paid, legal costs and claimants' legal costs, which is almost 14 million. And interestingly, not many go to trial, but I suppose that's probably true for a lot of litigation cases, but that does depend on the severity, as you very well know. So what are the themes? So I said I'm trying to help you develop a checklist of what to look for. So essentially, these tend to vary by the subspecialty interests that we'll talk about within the specialty. But if a lot of delays or negligence claims tend to be about referral pathways and delayed diagnosis. The other key point is inappropriate treatment. or appropriate treatment and you like, and whether people have been appropriately consented for it. Within the hospital setting, there tend to be risks such as operator error, and that usually comes from a different group of people under the banner of oral maxillofacial surgery. You can have a consultant clinic, but that could be served by a junior doctor. It could be served by someone who is doubly qualified, as in they have dentistry or medicine, or people with who are only dentally qualified, but work under the auspices of oral maxillofacial surgery. So nowadays, everything is about competency, proved skill set, and that's something to look out for when you get a claim to say so-and-so did this operation, it went wrong, or so-and-so saw me for a biopsy and an inappropriate biopsy was taken, or there was a delay in diagnosis. Some of the claims I've dealt with were due to unnecessary pain, either because of surgery that's gone bad or the morbidity following extensive surgery. And particularly relevant when we talk about morbidity is nerve damage, effects on function. Now, I've put dental damage there because sometimes it is not all maxillofacial surgery clinicians cause dental damage. It could be ENT surgeons, it could be anaesthetists, it could be A&E doctors, and that tends to stimulate litigation cases. So let's start. I tried not to include any gory pictures in there because I'm not sure what everybody's tolerances is, but I thought it's useful to have a radiograph just to illustrate some of the cases. So a lot of referrals come in about people who've had their wisdom teeth. Now, not everybody needs their wisdom teeth out. There are guidance, nice guidelines to suggest who should, what the indications are. But where the problem happens usually is wisdom teeth are removed, but there is damage to structures around the wisdom tooth, and these are demonstrated here, which is a nerve. So you think you're going for a relatively innocuous procedure. Yes, but we all know, you can get a fat hamster face and it's sore and swollen, but actually you can end up with a permanently numb lip and or tongue. So the issues here, as per that checklist, it's about competencies. Was the patient appropriately warned and consented? And in fact, did they need the tooth out? I've put on the right-hand side, might be your left, scans, CT scans. This is increasingly being utilized to discern where the position of the nerve is near the tooth. We have a lot of cases come through where people have gone ahead with suspicious association of the nerve with the roots, but they didn't go on to perform a detailed CT scan, which is indefensible nowadays. This is the category of dental alveolar surgery. These are dental implants. Now, there are two cases here that I've dealt with. One, as you can see, here is an implant. This is a normal tooth. Here's an implant. And just here, that black circle is a nerve. Now, those of you who remember the last image, I mentioned about a nerve that runs to the jaw. Well, it comes about here. And there's been times when people have put the implant straight into the nerve. Now, again, that's indefensible. And the reason that happened is poor planning. Now, these implants could be placed in hospital or on the high street. In the high street, dentists place implants. There are another category of oral surgeons that place implants. Lots of dental specialists place implants. So it's slightly unregulated. However, there are guidelines about what you need in terms of to achieve a safe implant placement and avoid morbidity such as that. This case should have really had a CT scan, three-dimensional images, so you know exactly where the nerve is in the jaw. Here, well, can you spot the error or mistake? Someone has placed an implant and it's gone into the maxillary sinus. Now, that's a definite no-no, indefensible. Again, that would have been probably due to poor imaging, but globally, as you look here, all these implants have lost all the bone. This is the bone, and usually it should be about this level, and that's due to poor placement and poor restoration. Now, you might say, well, do you deal with restoration of implants? And I don't, and usually maxillofacial surgeons don't. It's usually a restorative dentist or a dentist that deals with this. So in a situation like this, I can certainly comment about that and the placement of the implants, but you may likely need a report from a dentist or a specialist dentist to comment about the dental side, which is everything above the gum and out of the bone. Again, on this, they've missed a wisdom tooth with a cyst around it, which is again near the nerve, and this was not treated and eventually became a problem because the interest was all about the implants. So these are the kind of things in the category of dental alveolar surgery that could stimulate issues around breach of duty and causation. We'll move on to trauma. Now, the trauma cases I deal with could be either due to personal injuries, road traffic collisions, or occupational. And the majority of the times it's all about an incomplete assessment. So if we, just to illustrate this, the case on the left, this lady took her kids out to a zip wire kind of event, and another child on the zip wire knocked into her lip, causing a bad laceration. And you think, well, you know, that will heal. So why is it a big issue? The problem is when she went to A&E, they fixed the lip, but actually didn't remove the bits of teeth within the lip. So she had recurrent infections, which end up with very bad scarring. So it was an incomplete assessment by someone not within the specialty. But to be honest, this can also be missed by people who work within the specialty. So it's all about complete assessment and getting imaging or an X-ray to make sure there's no foreign body. This unfortunate gentleman this is an occupational injury when he should have been wearing a face guard, and a reciprocal saw basically came away, and this was a health and safety executive inquiry type thing, and he again was seen within oral maxillofacial surgery. The face was repaired, but they missed a fracture of the jaw underneath. And this was again a litigation, as he needed to go back to theatre and get that addressed. And there was also nerve damage, which was not picked up at the time. This poor girl went in for a normal procedure for a tonsil procedure, actually, and they knocked one of the teeth out. The anaesthetist knocked the tooth out. There are strict guidelines to say, well, if you knocked a tooth out, you need to do X, Y, and Z. Unfortunately, they didn't. And the tooth was left in a bag and handed to mum several hours later, by which time it was too late. Then it was replaced into the socket by the anaesthetist, but unfortunately the wrong way around. Anyway, suffice to say, the tooth was lost. She ended up with a permanent gap, and the other tooth migrated into the gap. So now she needs quite complex orthodontics. So here we'd get a report from an orthodontist as well as a surgeon, and will require implants at quite a high cost. And when you put an implant in, you know, that's not guaranteed lifelong, so you may have to have it replaced. So there are issues of quantum down the line. Just one thing to say about the trauma cases, maybe for not this case, but the others, we recommend, but suggest when you ask the question, do you need any other expert opinion? It's usually a psychologist, because a lot of them tend to have post-traumatic stress disorder following the trauma. Here is another few trauma cases. This is a child. As you can see, the pupil levels here is different, and the reason for that, they're able to look up but here they can't. And the reason for this, they have something called an orbital floor. So usually the eye sits in here. These are the muscles that move the eye. And there's a muscle at the bottom there. And classically in children, they present without any redness if they had trauma to their orbit. And it's called a white blowout because it's white, but the muscle, the floor has blown out and the muscle is entrapped. This was missed, delayed presentation. The issue with this is the muscle here can die, leaving a permanent visual deficit, permanent double vision. And this was a litigation case. This was missed by more than one A&E, despite the CT scan. Nowadays, a lot of out-of-hours CT scans are reported from a peripheral source. It's not someone in hospital, and the reports tend to have a lot of variety in terms of quality. This gentleman here, unfortunately, was riding an e-scooter, which I learned seemed to go at a very fast pace, I think about 20 to 30 miles an hour apparently. And he suffered quite a bad break in the jaw. This was a sort of a personal injury claim because a car pulled out at him and he came off the e-scooter and landed on his jaw. This required complex reconstruction, several hours at theatre. So this has an implication to the sensation of the lip because the nerve was damaged, to overall continuity of the jaw, eating and drinking, and loss of a lot of teeth, which needed dental rehabilitation. So on this case, this involved a dental opinion, myself, a psychologist, and there was an opinion from an A doctor because he was trauma called in because of the speed of the injury and he'd lost consciousness. This is a personal injury case where this gentleman sustained a trauma to the cheekbone. This is the cheekbone here. This is the orbit, which you remember from this slide. The issue is here is they missed nerve damage in this area, and he presented several weeks later. There was an opportunity to repair this nerve so he can have sensation in this area, but this was missed. They fixed the bone, but they forgot about the nerve in the soft tissue. So again, an incomplete assessment. We get a lot of trauma, as you can see. This lady had a very bad laceration or cut here, and this was sutured inappropriately cleaned and sutured by a junior member of staff. This should have been referred up to someone more senior and debrided, cleaned in theatres. It was done with the patient awake, which was quite traumatic for them, but it ended up with terrible scarring that needed quite extensive scar revision, costing several thousands of pounds. And here, this is just, I can't put it any other way, but shocking surgery. This is badly performed, fracture fixation. You can see that this is not in line, and the patient's bite was off. They required a repeat procedure. They missed infection around the tooth that should have come out at the same time. Again, incomplete assessment and substandard treatment. We'll change topic. Another increasingly common claims are with temporomandibular joint. So this is the joint right in front of your ear, the jaw joint, and this is attached by muscles to the rest of the face. This is where you get pain when you've had a stressful day, when you're clenching and grinding your teeth. Now, this was an alleged assault. This chap was a singer, and they missed this break. So there were two issues here. One, the alleged assault, and two, this was missed. And this led to an abnormal bite, but worstly, difficulty in mouth opening. And this claim settled for £1 million because it affected future career earnings. There's increased interest in TMJ surgery, especially arthroscopy for facial pain. And the kind of cases I've come up, well, I've been instructed with are relating to inappropriate surgery because a lot of jaw joint surgery, the management tends to be non-operative in the first place, but there is a trend to jumping in and doing arthroscopies that may complicate issues. These patients can be complex with regional pain syndrome, and they present with headaches and migraines, and they're not really investigated appropriately. People jump in and decide to operate on the jaw joint. And you can, if I just go back one, this is a disc in between, and people tend to do surgery to reposition the disc as opposed to addressing all the other issues. Now, disc repositioning is very susceptible to relapse, and people come in complaining a year later that their symptoms haven't settled, and you request MRI imaging, and they show that actually whatever surgery they've had has relapsed, but they're not warned about it. So it's a consent issue. I've had cases where, because of several of these arthroplasties, where you put a scope in the joint and you can, for example, reposition the disc, there's been a lot of scarring and they've had chronic pain, and so they've become accustomed to opiate use, and they've basically, the pain complex has become a chronic pain issue, not one to be taken lightly and even attempted to resolve with surgery because of all the scarring of the soft tissues around the jaw joint. I've had one case where actually patient was unfortunately coerced into surgery, so to allow trainees to practice, because, as I said, the surgery is not common, but it's becoming more common, so people are very keen to get their hands on when they are trainees. We'll move on to another subspecialty of oral maxillofacial surgery. It's got a fancy name, orthognathic. It's essentially facial disproportion surgery. So I'll just briefly explain to you here. It's essentially moving the top and or the bottom jaw to achieve a better aesthetics to the face and a better bite. So it could be that your teeth don't completely close, or your front jaw is on top of is in front of your top jaw or behind it. Now, these cases are approached in a multidisciplinary way, in that they could involve a dentist, an orthodontist, a surgeon, a psychologist. So there can, it's not even a new buzzword anymore, but multidisciplinary team. And they should, all these cases should go through multidisciplinary team meetings to discuss each individual case with the patient. Now, the cases I've dealt with have all centered around patient dissatisfaction with the treatment they've had and poor communication. And that's always a risk, isn't it, when you're involving lots of people and not managing the patient's expectations. The sources of litigation can come from major complications. Now, the majority of these patients are young, fit and well, so you're not going to get that mortality picture with more complex surgery. This is all about morbidity, which is, so one current claim I'm dealing with at the moment is surgery that involved essentially in this surgery you have to divide the jaw, and basically there was an unfavorable break in the jaw for lots of reasons. But the claims can center around poor aesthetics. When you move the top jaw, you can influence the appearance of the nose. I've dealt with cases where that hasn't been addressed and the patients woke up with a bent nose or the nose being of different shape. Their bite could be abnormal and not what they expected it to be following surgery. And that could be part of the plan for surgery to be corrected with orthodontics down the line. But the most common is nerve damage. Again, it's that nerve that I showed earlier on with the x-ray that runs through the jaw. That could be damaged, leaving with permanent numbness. Temporomandibular joint or jaw joint issues, as I alluded to in the last slide, because you're moving the jaws forward and back. So these things need to be identified and patient risk stratified before facial disproportion surgery, because if they're at high risk, they need to appropriately be counseled that surgery may not relieve the pre-existing symptoms. And another growing field is obstructive sleep apnea. So I dealt with a case where a gentleman was a train driver, and essentially on a lucrative salary, but he was stopped because he had daytime somnolence. And he found that he had poor sleep, obstructive sleep apnea, so underwent surgery to move the jaws forward to open up the airways. Well, unfortunately, that didn't improve his sleep, and he never went back to his lucrative job. So he essentially followed the litigation path to say, well, the treatment had not delivered what it was meant to do. So you just got to be a bit careful with what the patients are expecting and the communications around that. And finally, sorry, I know there's quite a lot there. We talk about head and neck cancer and reconstruction. As you can see from here, we covered maxillofacial surgery, quite different elements of cancer. So oral cancer, which is what I mean by head and neck cancer, including involvement of lymph glands in the neck, skin cancers, and salivary gland cancers. The biggest issue, the most regular sort of source of cases, is delayed or misdiagnosis. And it tends to be actually more than, this is quite big, involved surgery. It tends to be more than the morbidity from surgery. And the issue with delayed and misdiagnosis is obviously its impact on the extent of surgery and whether reconstruction is needed, and also mortality. And that, as you can see, the biggest sums, this is an American paper, tend to be, these delayed misdiagnoses. And that was my initial slide to say, look at the pathway where they refer, and there are NHS guidance as to whether a patient should be referred to which specialist in what time frame, and also the time frames that the patient must be treated, and whether, if they've had investigations, these investigations were appropriately followed up. And now just a bit more, because the time delay has a really big impact on quantum when you're trying to assess the merits of a claim. A common question I'm asked by lawyers is, well, is a delay of a month significant, 6 months? If the delay was 3 months, would it made a difference? Whether that influenced the type of surgery or the mortality risk in the long run, or risk of recurrence. And it's interestingly, when you look at claims, the 3 months versus delay of more than 3 months, there's certainly a difference in terms of the award level, given when cases settle, because a lot of these cases don't go to court. But again, it's the failure to refer because pathways were not adhered to. And I've had 3 cases now where, I don't know if any of you are involved with dental claims, where dentists have failed to recognize that someone has had previous cancer therapy, and it's mostly radiotherapy, and proceeded to take a tooth out. The problem with that is the jaw does not heal, and it precipitates a condition called osteoradionecrosis. That is bad news, because this may not only unfortunately causes pain and suffering, this may need quite complex surgery requiring reconstruction, which is very disabling. And I think I've had at least 3 to 4 claims that I've settled because of that. And then, so broadly, the risks with all of this head and neck cancer kind of paradigm is the extent of the morbidity, recurrence, and mortality risks, because it's not unusual that some of the cases that I've dealt with is where the estate of the deceased is actually litigating for breach of duty and causation. As I said, I'm more than happy to share all of the papers. And if you have any questions, yeah, more than happy to answer.